Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. I'm the medical author of the book Focused Neurology. My email is 3klpm@gmail.com. Today we are going to talk about a very fascinating topic, HINTS, to differentiate the brainstem stroke versus APV, acute peripheral vestibular disease. HINTS. But what is HINTS? Head impulse test, nystagmus, and test for skew. It is the cranial nerves part 60, vestibular cochlear 8th nerve part 10. So we'll be talking about HINTS. What is HINTS? HINTS is head impulse, nystagmus, and test of skew. So it's a three-step bedside examination which is touted as a reliable way to distinguish brainstem stroke from acute peripheral vestibulopathy. So it's a three-step bedside examination to differentiate brainstem stroke from acute peripheral vestibulopathy. So now let's go step by step. Step 1. The head impulse test, the head thrust test. The doll's eye test utilizes slow side-to-side head movements in a comatose patient, whereas the head thrust test is done in an awake patient. A very important difference. The doll's eye test utilizes slow side-to-side head movements in a comatose patient, whereas the head thrust test is done in an awake patient. Abrupt, rapid movements are made in each direction while the patient attempts to maintain fixation straight ahead as on the examiner's nose. The ocular smooth pursuit mechanism cannot compensate for head movements done at such high velocity, but the normal vestibular ocular reflex will maintain fixation and the eyes will hold on the target. When the VOR is impaired, the compensatory eye movement velocity is less than the head movement velocity. The eyes lag behind the head movement and a corrective catch-up second must be made to resume fixation in the eccentric position. So when the VOR is impaired, the compensatory eye movement velocity is less than the head movement velocity. The eyes lag behind the head movement and a corrective catch-up second must be made to resume fixation in the eccentric position. I'll show you the diagram, then it will be better understood. So this is the diagram, head thrust test with the defective left labyrinth. So you can see here the normal patient maintains fixation throughout. The patient with the defective labyrinth, example left labyrinth in this case, loses fixation with the rapid head movement and must make a catch-up second to the right. So let's see the normal. This is the normal. So the eyes are fixed on a particular object. Example, the examiner's nose. The head is turned to one side, but even when the head is rotated to one side, the eyes are still able to maintain fixation on the particular object, example the examiner's nose. So fixation is maintained if it is normal. Now let's see what happens if there's a defective left labyrinth. So when there's a left labyrinth is defective, what happens? So again here the patient is looking straight ahead, fixation being on the examiner's nose, and then suddenly the head is rotated. But here if you see, when the head is rotated, the eyes are also rotated along with the head and misses the target. So the fixation is lost if there's a defective labyrinth, in this case left labyrinth. So what happens? The patient must make a corrective second. Patient must make a corrective second again to fix it exactly on the object, example examiner's nose. So this is known as catch-up second to the right. So this is the wonderful head thrust test in this example with a defective left labyrinth. The normal patient maintains fixation throughout. The patient with the defective left labyrinth loses fixation, the eyes also moves along with the head and with the rapid head movement, and the person must make a catch-up second to the right. So this is beautifully illustrated in this diagram. So this is the head thrust test with the defective left labyrinth. This is the first step, that is the head thrust test. So you look for the vestibulo-ocular reflex impairment, head impulse test. The second step is the nystagmus. Peripheral nystagmus is usually unidirectional, whereas central nystagmus may be directional. So peripheral nystagmus is usually unidirectional, either beats to right side or to the left side, whereas central nystagmus may be bidirectional. It may beat to one side, that is the right side, come to the center, and when you turn to the left, it may start beating to the left side. So right side comes to the center, then may start beating to the left side. So it may be bidirectional. So peripheral nystagmus is usually unidirectional, whereas central nystagmus may be bidirectional. The slow phase of spontaneous vestibular nystagmus is usually in the direction of the lesion, whereas the fast phase away, because an acute vestibular lesion typically causes hypoactivity of the labyrinth. So when there is a hypoactivity of the labyrinth, the opposite labyrinth will push the eyes towards the side of the lesion and the nystagmus will be to the opposite side. So the slow phase of the spontaneous vestibular nystagmus is usually in the direction of the lesion, with the fast phase away, because an acute vestibular lesion typically causes hypoactivity of the labyrinth. And another important point is that when evaluating nystagmus, the presence of a torsional component suggests a peripheral origin. The presence of a torsional component suggests a peripheral origin. Why? This is because of the influence of the three different semicircular canals. Vestibular nystagmus may beat in more than one direction, the summation of which creates an admixed rotatory component. Yeah. So now we have seen the first step, head impulse test. We have seen the second step, the nystagmus. Now we are going to the third step, the skew deviation. What is skew deviation? Skew deviation refers to a vertical misalignment of the eyes that commonly occurs from acute brainstem lesions which disrupt the pre-nuclear vestibular pathways to the third and fourth nerve nucleus. We have the pathway for vertical eye movements coming from the eighth nerve going to the third and fourth cranial nerve nuclei, which are in the midbrain. So if there is a disruption of this pathway, there could be a vertical misalignment. So skew deviation refers to a vertical misalignment of the eyes that commonly occurs from an acute brainstem lesions which disrupt the prenuclear vestibular pathways to the third and fourth nerve nuclei. Presence of skew deviation indicates a central pathology. Presence of skew deviation indicates a central pathology. The alternate cover test is used to detect skew deviation. First, the examiner covers one eye of the patient with the card and moves the cover to the patient's other eye while looking for a vertical corrective movement as an index of a vertical misalignment. So if there is a skew deviation, again it indicates a central pathology. So if we go step by step, HINTS, head impulse test, nystagmus and test of skew, we can differentiate whether it's a central cause or a peripheral cause. So these are the wonderful concepts of HINTS, head impulse test, nystagmus and test for skew. I hope you have enjoyed listening these wonderful concepts. The other important concepts of neurology I put in a book called Focused Neurology, written by me, Dr.Sreenivas, in a question and answer format, which will be very useful especially for students. This book is available online from all leading booksellers including Amazon. So if you are interested, this book could be purchased online. I hope you have enjoyed listening to these wonderful concepts on HINTS. If you have enjoyed it, please like and share the link. But please subscribe to my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.